It's nice to meet you all. I'm Michelle Patriquin. I'm a psychologist in Houston, Texas, at the Menninger Clinic. We're inpatient, outpatient hospital, psychiatric mental health hospital. And here I'm actually director of research here. So a lot of what I do has to do with data and numbers and research and thinking about mental health outcomes for people at our hospital and beyond, and how we use data to better understand and make better outcomes, especially for people who might go to higher levels of mental health care, like inpatient. But my first sort of interest and love and kind of what I'm really most passionate about actually is autism spectrum disorder. And I studied it in undergrad and then grad school and really thought a lot about it, particularly when I was really interested and really thought a lot about how biology and the way we respond physiologically changes the way we interact with our environment and oftentimes other people. So I've thought a lot about that and worked on a lot of studies around social behavior and physiology, and really around how sometimes when, especially if we're nervous or we are in any sort of kind of state, that this fight or flight state, that we can really struggle socially and interacting with other people socially. It can be hard to kind of know the right thing to say. It can be hard to look at people in the eyes. And so have really thought about that a lot, just kind of broadly, but also specific to autism spectrum disorder too. So I'm a child and adolescent psychologist by training, and but now I kind of work with anyone. And in the end, we all grow up. And so, we all were children at one point, and then we kind of, right, have all these experiences that we take with us into adulthood, and they can impact us in different ways. And that includes kind of psychological experiences, so things that have happened in our worlds academically or socially, whether things were positive or negative for us socially, but also our biology and how things change for us biologically, the way we respond to the environment. And I have slides. I don't know how formal we want to do this, and I want to do whatever is most helpful for you all. So you have my time. I have slides where I could kind of share with you about our findings over the last decade of research, and then we can have a discussion at the end, or we can just have a discussion and Q&A. Yeah, I see a question already, I think, in the back. Yeah. Sure. So that's a really good question. So PDD-NOS actually doesn't exist anymore formally as a diagnosis. And so when you were in high school, it would have still been around. So how we diagnose disorders, mental health disorders, right, all come from the Diagnostic Statistical Manual, the DSM. And in 2013, they revised the criteria for autism spectrum disorder to not include pervasive developmental disorder, NOS, not include Asperger's disorder, not include Rett's disorder. So in May 2013, they made this huge flip when it comes to autism spectrum. So prior to this change in the older DSMs, you actually had this umbrella. And it was such a nice way of thinking about it, because you had this umbrella of autism spectrum disorders, plural, with an S on the end. And that's super important because you had this umbrella and then you had different categories or diagnoses under that umbrella. So autistic disorder, that was its own label and diagnosis. Asperger's disorder, that was its own label and diagnosis. PDD-NOS, its own label and diagnosis. Rett disorder, separate own diagnosis, all under this umbrella of autism spectrum disorders. In May 2013, they revised it based off of clinical opinion and research studies to be considered autism spectrum disorder, singular, and then they got rid of all of those different categories in terms of labels. I know so many people though who really prefer those labels, especially when it comes to Asperger's disorder or Asperger's, really identify with that. And so, you know, like clinically, I'll say, well, this would make sense for Asperger's, or, you know, in the past, or you might even just want to Google Asperger's when you think about this diagnosis. Now, yeah, I see a couple of hands. There's also one hand in the back in the corner. So I just want to keep, maybe I think in the back was first and then Rachel. We talk about prevalence rates. Those are actually the ones that are published, like the ones you see on the CDC are actually in 8-year-olds. It's a very specific age. And so, you know, there's limitations to that. And sometimes it will only be, the sample only comes from a few states as well. And so you got to take it all with a grain of salt. But it does seem to be rising, and there's a lot of things kind of at play that people say, and no one knows exactly what is, you know, weighted the most. Is it just that we are becoming better at screening? Potentially, and the assessments are more readily available and becoming even more so now that there's more telehealth options as well. So more access to care and assessment. And it's hard to know if there's a true increase in the incident rate or prevalence rate, but it does seem to be rising. I don't know. Was there more to your question? Really good question about false positives. I don't actually know the exact stat on that. I will say, just from clinical experience, it does seem fairly rare to have a false positive, because oftentimes you also have providers following individuals on the spectrum for longer periods of time. And so you will have kind of a good especially now when we can get good early developmental history and kind of be looking for early signs of ASD versus, you know, maybe people who are much older and already kind of past that early developmental and childhood period. So I think, yeah, we've gotten better. Yeah. Yeah, so they didn't talk to you about it until you were older. I think Rachel also has a comment too. Super good question. So one of the key things that we do are well, two big things we do. One is a test called the ADOS. Has anyone heard of that? Does that sound familiar? Autism Diagnostic Observation Schedule. So that is kind of a real-time observation with a clinician, and they interact with you. They look for your understanding of emotions, of social situations, of your hopes and dreams for the future, but then also about how you can your creativity. So even looking at, like, can you and do you kind of flexibly use objects to be something that maybe they're not intended. Like I would have a pen and, you know, this, you know, looks like a pen to me, but on the ADOS, I would ask like, oh, you create a story out of that? And so like, could the pen also be like I don't know, like rungs on a bridge or a car or something like that. And so we look for creativity. We also look for restricted interests and repetitive behavior. So someone mentioned that you can have kind of a focus on a certain topic. And so when someone talks about a topic, can they transition off of that topic and follow, like, for example, a conversation? So I might say something like a statement and see if that person can follow my statement and maybe start a conversation with me. And so we look a lot at current social behavior, communication, but then also the presence of restricted interest and repetitive behaviors. And then we also do the interview, the ADI, Autism Diagnostic Interview. That interview you do with parents or caregivers. And that's where you really look and think about early developmental history. So we look especially at the age of 4 and 5. Someone mentioned they were diagnosed around 5, and that's usually when symptoms become most apparent, oftentimes because the child can be in a school setting of some kind, so preschool or daycare, and differences sort of and difficulties can emerge that make it a little bit more clear at that time. Yes and no. It depends on who you are. So for some people, yeah, there's a difference for sure. For some people, no. And you can there's more of an overlap or co-occurrence with OCD. So it really kind of like all things, like we always talk about, everyone, you might say, people have autism spectrum disorder, but that looks so different, right? The kind of pieces that make up that puzzle and the differences and the combination of them are very different based on who you are, just like every person. So the answer is yes, there can be overlap and similarities, but it really depends on who you are. And I think as time has gone on, we've gotten much better at something called differential diagnosis because our tests have gotten better, our assessments. So what I mentioned before, the ADOS and the ADI, look at specific restricted interests, repetitive behaviors that are key for autism and specific to autism. And so it can really like extract what might be OCD and then what might be more related to autism spectrum. That is a good question. I think as a field, right, for mental health care, that is a problem not just specific to ASD. That is a problem that is pervasive across mental health. Actually, one of the reasons why I'm so interested in research is to make that better, to make assessments better, to make them more specific. And so we don't have so many changes, right? Because once we get changes in terms of someone's diagnosis or it doesn't seem to be the right fit, that means treatment will follow, right? And so then we get treatments that are off course, and you may do one treatment over here, one treatment over there, like with different diagnoses, and it can get it's not algorithmic right now. Like if you have cancer, it's pretty algorithmic what should happen, and there's a kind of clinical decision making and process that's data driven. In mental health, it is not the same way. That's what we work on every single day here at Menninger, is to make it data driven and to make it research based and to really the best we can make it so that you don't have cases of this false positives, like someone mentioned, the misdiagnosis, and that becomes much more structured and concrete, the way we are diagnosing, and then ultimately the way we connect those diagnoses and symptoms and problems to treatments. Very, very good question. And actually, a lot of my research has focused on peripheral nervous system activity. And with that, you'll find a very high prevalence rate. So one thing that you see in autism spectrum disorder is that actually people on the spectrum are in a higher autonomic activated state. So more fight or flight, a higher fight or flight response than people who aren't on the spectrum. And because of that, that means that something called the vagus nerve, so it's a nerve that runs from our brain through our brainstem and controls our peripheral organs, is actually not online as much as it should be. So on the spectrum, it's actually, we talk about the vagus being a brake. So it slows everything in our body down. But in ASD, that brake isn't on. So we have higher heart rate. Our hearts move faster and beat faster than individuals who aren't, on average. So not everyone, there can be variation in this. And then also, so not only does the vagus attach to our hearts, but also attaches to our lungs. So we can have kind of breathe faster and maybe hyperventilate more, or just have a higher respiration rate. But then it also innervates or connects to our gut. And so our gut is actually also then, well, I think, one thing that also is different, and I love all the biology. One thing that's also different is responses in the insula. And that's the perception of that feeling, and how you feel physiologically, and therefore, how you may respond to it. I especially have done it with younger children. So younger children in that state can actually engage in repetitive behaviors to try to soothe that autonomic state. Well, there's some literature to show that that does help a lot. And it's a really effective coping skill, to kind of really reduce that activity, and that feeling of activity inside your body. And I think, that is an additional thing, is that your body, if you're on the spectrum, may feel different. Your response, and maybe more intense than people who are not on the spectrum. It may be overwhelmingly intense sometimes, right? And so that's why you might see children who pace the outside of the walls, or pace in general, adults who may pace, and then engage in some sort of stimming or self-soothing behavior too, to calm that state, because it feels different. It is different, and it feels different, and can feel way more intense, potentially. Very good questions. The answer is, do we have the answer? No. I for those topics, do we have answers, ideas? Yes, for sure. I think, when it comes to meltdowns, I think that's part of the kind of physiological response and differences. It can be very overwhelming, changes that may seem sort of minor to people who are not diverse or neurodivergent. Maybe there's a change in plans. For people who not on the spectrum may think it's no big deal, but it may cause or generate a physiological response that is extremely intense, and hard to manage, for someone on the spectrum, and then relates to a meltdown, for example. I really love a topic called physiological synchrony, and it really, just Google it, start looking at it. It's super interesting. And I think my hypothesis would be, there's some literature to show that people on the spectrum are more in sync physiologically, and then that translates into emotionally and behaviorally to each other. And there's a better understanding cognitively, but then actually you are like physically responding in a similar way, and you understand and you have similar feelings to similar things, and that shared experience helps to connect you, and helps to connect you in terms of how you think, right? And because you actually feel similarly. I really, I think that is super interesting. And it can also that physiological synchrony actually can become asynchronous too. So maybe if you've ever found yourself with someone who was not on the spectrum or not neurodivergent and finding, whoa, I really cannot connect with this person. It may also be because you feel differently than they do. You feel differently in certain situations, so you do not have shared experiences, and that can then translate to differences in how you understand emotions and behaviors, things like that. Well, thank you so much. Thank you so much for having me. And I'm so proud of you all having this group and forming this community. Just fantastic. And thank you so much. I just want to say thank you to Rachel too for inviting me. This is really special, and was very honored to be invited. So thank you for having me. And